Dr. Kaliamurthy shares his knowledge with trainees from various specialties with a primary emphasis on addiction. Additionally, he collaborates with local school districts and health departments to proactively address substance use prevention among young people in a career dedicated to advancements in pediatric substance use disorder treatment and research. Just one housekeeping note, please enter your questions in the chat box and watch out for an email in the coming days explaining how to claim your CME credit. This evening's presentation is entitled Substance Use in Adolescents, A Shifting Landscape and Its Psychiatric Fallout. Take it away, Dr. Kaliamurthy.
Thank you for that wonderful introduction, Dr. Rudorfer. And it's nice to be here. Thanks for the invitation to talk to the audience and members of WPS. And I thank you for everyone who's here on an evening when they'd rather be spending time with their family. I'm going to focus today on talking about substance use in adolescents, but also keeping in mind that I know I'm talking to physicians who are seeing adults. So I kind of, when I was putting this talk together, it was really focused on how do I explain the implications of what kids are doing now and how this is going to affect them as they continue to grow and what you might be seeing in your clinical practice. In terms of disclosures, this is the most recent disclosure. I'm on a data safety monitoring board for a medication trial with Tranquil Research, and I'm not talking about that medication in this presentation. Other disclosures, if at any point during this talk today, if you hear any blood-curdling screams, don't be alarmed. It's my 4-year-old trying to avoid bedtime with his mom. And he may pop in to say hi at some time. So in terms of learning objectives, today, we're going to talk about emerging trends in substance use among adolescents, how it has really changed recently and what we should be watching out for, and examine the psychiatric implications of this change. And finally, appraise strategies for early identification and intervention. I specifically am going to also talk about what we are seeing on the ground in Children's National, where we see kids from the DMV, some trends that we are noticing, and share some data from that perspective, and also what we are doing in terms of trying to intervene in this geographical region. But I'll start off with substance use prevalence data. I have this tendency to ask my pediatric trainees and child psychiatry fellows this question of their personal thoughts on whether substance use in kids has gone up, down, or stayed the same, and I always get the answer that it has gone up, right? But the data does not show that. So this data is from Monitoring the Future survey. It has been around since almost the 70s. And I'm going to focus on the 3 most commonly used substances by kids, which are cannabis, nicotine, and alcohol. So if you see the rates compared to 1990 till 2024, for which we have data, we are at historic lows almost for substance use overall, right? This is the graph on the left shows you data for the last 1 year or 12-month prevalence, and the graph on the right shows the last 30-day use. And the trend is very almost similar for marijuana, alcohol, any illicit drugs, and nicotine vaping, which was a recent data that was, they started collecting around 2018, 2019. So why is there that bias that when I ask our pediatric trainees and our child psychiatry fellows what their thoughts on this trend is at the same time, what we are noticing is that there has been a significant increase in substance-related visits and inpatient admissions in this population. So in this data that we collected from the Pediatric Hospital Information Systems, which collects data from about 47, 48 children's hospitals across the country, there has been a 50% increase in substance-related visits in this population between 2016 to 2021. And these ED visits are also leading to admissions into the hospital. And the increase was there for all demographics, regions, and encounter types regarding whatever the substance-related visit was. During the COVID-19 pandemic, there was a statistical difference in terms of a specific subgroup, which was more than expected visits among publicly insured females, non-Hispanic, Black, and Hispanic youth. And overall, as a demographic group, Hispanic youth experience the greatest percentage growth of all substance-related encounters when compared to non-Hispanic white youth and non-Hispanic Black youth. So this is essentially that discrepancy that we are seeing, which is the overall prevalence of substance use is low, but the problems associated with substance use and substance use disorders are going up. And this is something that we will kind of dive into more as we continue talking this evening, or as I continue talking this evening. So key take-home points: substance use prevalence is on the decline, but problematic substance use may be going up. The reasons may be change in access to these drugs, social media, how kids get access to drugs and the ease of that, change in potency of the substances, we'll talk about that, increase in mental health concerns, and a lack of identification and intervention in this population. So now we are specifically going to start talking about opioids. I mentioned that cannabis, nicotine, and alcohol are the most commonly used drugs, but opioids, unfortunately, has a significant mortality associated with it. And it also has proven evidence-based treatment that's hardly utilized. And I'll kind of go over the data. The graph that you're seeing here, I don't know how many of you have seen this before, but this is very, very popular in pediatrics. This study came out in the New England Journal of Medicine in 2022. And the reason this became popular was because for the first time in 2020, we identified firearm-related injury as the leading cause of death among children and adolescents in the United States. But in that same year, I circled this in red, the drug overdose and poisoning-related deaths also went up, and that was the third most common cause of death among children and adolescents in the United States. Now, one of the reasons for this is we saw that the prevalence of substance use is coming down, but if you see the graph on the left here, it shows the substance associated with overdose deaths. And you see that fentanyl, which has increasingly crept up in the drug supply, has contributed to a lot of this deaths, especially given its potency. And we can also see in terms of overall mortality split by race and ethnicity, American Indian or Alaskan Native non-Hispanic seem to be the worst hit, and followed by the Latinx community. And this data is still old in terms of 2020, 2021, but we know one thing, the numbers haven't really gone down. They've stayed the same since about the peak between 2019 to 2021. And in terms of overall concerns around overdose deaths, one of the main challenges we are seeing is about 24 to 26 kids die every week from drug overdose in this country. And to put that into perspective, in the US, that's a high school classroom worth of teens who die every week from drug overdose. Now, most of you might be aware that overall drug overdose deaths have been on the decline in this country. There's a lot of reasons attributed to that decline. Two of which I want to bring up are increased access to naloxone and increased access to medications for opioid use disorder. We still don't know if that is true for the pediatric population. And the data so far suggests that that may not be true. So that's the overdose death, but what about the prevalence of opioid use disorder as a diagnosis? So all indicators from the National Survey on Drug Use and Health shows that while overdose deaths are going up, the rates of kids struggling with opioid use disorder is also going up during this time frame, right? So between 2020 to 2023, what you can see in blue is the number of kids with opioid use disorder between the ages of 12 to 17. And in orange, you have the prevalence of opioid use disorder in people ages 18 to 25. So as of 2023, approximately 320,000 kids ages 12 to 17 have or potentially have a diagnosis of opioid use disorder in the US. So what are some challenges in treatment? And I'm going to also bring this graph that you see on the right-hand corner, upper corner of the slide. This is the same paper I spoke about that showed an increase in hospitalization split down by substances. During this time, we saw a 20% increase in kids coming to the hospital with opioid-related concerns. Now, what happens to kids is we know that less than 1/3 of kids or youth between 13 to 22 receive timely addiction treatment after an opioid overdose. and only 1 in 54 youth received any evidence-based pharmacotherapy. This was a striking discrepancy. In 2023, this is the NSDUH data. The combination of 12 to 25-year-old who had opioid use disorder was about 712,000 people, but we only had receipts for about 40,000 of them who were dispensed buprenorphine, which is FDA approved ages 16 and above as a treatment modality for opioid use disorder. But what happens after you initiate medications? One of the challenges, especially I see this as a clinician, is keeping kids engaged in care, especially when substance use is a co-occurring concern. And that's always a challenge. So when we do start kids on MOUD, we still don't know whether there are differences between buprenorphine, methadone, naltrexone. And before the fentanyl era, we knew that methadone was generally the medication that led to the most retention. But methadone also has its challenges in being prescribed in pediatrics, and we generally use that as last resort. And finally, resource limitations. The number of treatment centers, the number of programs that cater to kids struggling with substance use disorders using evidence-based intervention is extremely bad in terms of the access and availability. For example, this one study, which was like a blind telephone call to facilities inquiring about their treatments, found that only 1 in 4 residential addiction treatment facilities for adolescents offered buprenorphine, which is FDA approved and evidence-based. In contrast, more of them offered equine therapy for substance use disorder treatment compared to a medication treatment. And what about local data? So in my role as the clinician in the addiction program, we've been kind of trying to find ways to track this data. And we did recently publish information on the kids that we were seeing with opioid use disorder who are primarily using fentanyl. So for most of these kids, this is DMV specific data. All these kids are from mostly DC and Maryland. Given the location of my clinic, some fewer of them are coming from Virginia. So mean age at intake is usually 16 and like half or 17 almost. I've had some kids come in as early as 14. And for these kids, the age at first use of opioids, and this is almost always fentanyl, which is a contrast from adults who started prescription medications, heroin, and then escalated to fentanyl. Kids are starting fentanyl as the first point of entry into opioids, and that is about 15 and 15.4. Kids predominantly in our region tend to smoke, just putting these pills in a foil and heating them up and inhaling them. Age at first use of any substance, typically cannabis or nicotine, is 13. And high rates of co-occurring substance use disorder. If a kid has OUD, they're more likely to have cannabis use disorder, nicotine use disorder. But interestingly, we also found high rates of psychedelic use. So in this clinical sample, we found 50% of the kids reported using psychedelics, typically psilocybin and LSD. Because we're an outpatient clinic and nobody's forced into treatment, almost always kids had family involvement. They were all accepting of treatment for medications. And in our clinic, we found that 60% of them were retained at 3 months, which we don't really have comparison data, so we don't know if we're doing a good job or not at this time. And we tried to connect these kids to intensive outpatient therapy, in-home services, but we generally find that there's low utilization of psychosocial services. Most of the therapy and medications they get is from those office visits that they come and see me at the clinic. And more recently, things that we have been doing, unfortunately, is starting these kids on long-acting injectable of buprenorphine. I don't know of many other clinics in the country doing this work, but we've generally found that using extended-release buprenorphine for kids seems to do overall much better in terms of outcomes, treatment engagement, their ability to go back to school successfully, and staying away from fentanyl overall. We haven't published this data yet, but when we have kids on injection compared to the sublingual forms of buprenorphine, the kids on injection seem to be doing better at this time. So challenges for us, we don't know how long they need to be in treatment for opioid use disorder with medications. We don't know what weaning off strategies are effective and when to do it, and what the long-term consequences are. So as you know, when you're in your clinical practice, seeing adults, you're going to be seeing a lot of these patients hopefully who are started on medications for OUD as kids. And we need to really understand better what are safe, effective ways to help them. Do they stay on the medication? Do they not stay on the medication? And how do we get them off if they want to do that, etc. So in terms of take-home points, we really need to do more to decrease drug-related overdoses in kids. It's a very preventable cause of death at the end of the day. We need to increase access to evidence-based OUD treatment for kids. And I'm going to kind of segue into nicotine, which is also had a lot of significant changes in the drug itself in the last 10 years or so. So good news is overall, there is a decline in vaping of nicotine among kids. Cigarette smoking is at an all-time low, which is also great. But as of 2024, we have about 2.25 million middle and high school students who report current use of any tobacco product. And this was even from 2023, when it was 2.8 million. It's a significant decline. And cigarette smoking right now is at the lowest level ever recorded by the survey. This is the National Youth Tobacco Survey. But right now, 1.4 students report current use in 2024. But what has happened to nicotine itself? So nicotine, as we know, is a naturally occurring parasympathomimetic that we extract from the tobacco plants. So historically, the nicotine that, the tobacco that is gotten from the plant and the way that cigarettes were packed, the pH was generally almost neutral to alkaline. And this kind of had a cap in how much nicotine could be packed into a cigarette before the nicotine itself became quite harsh and intolerable to the consumer. What has happened now is that with the advent of the vapes and the electronic devices, they have decreased the pH of nicotine and made it into a salt. And you will often find that kids talk about salt nic or nicotine salt in terms of 5%, 3%, or sometimes even 8%. So the nicotine itself, the structure of the nicotine that's being delivered to the user has changed significantly. And we know that kids are not the ones who are smoking cigarettes and switching to vapes. They're rather starting off with vapes, which contain nicotine salt. So we don't know a lot about nicotine salt just yet. So, and it's still an area of study that's going on. What we do know is some studies that have happened in the past. This specific graph was taken from a class action lawsuit in California against Juul Labs, which initially created this product, and this was from their patent filings. So in the x-axis, you see the time after first puff, and in the y-axis, you see blood nicotine. In the graph in blue is your regular cigarettes, and in red is the 4% benzoate nicotine salt. What this graph shows us is that potentially 5 minutes after first puff, the blood nicotine concentration for a salt nicotine might be much higher than regular cigarettes. But also from minutes 5 to 10, you see a significant decline in the levels of nicotine at the same time. We believe that this may have more reinforcing effects. And I'm saying may and we believe because these have not been conclusively proven at this time. What do we know about nicotine in the adolescent brain is that there are differences between adolescents and adults in terms of how the body reacts to nicotine. In terms of acute nicotine exposure, we know that in the adolescent brain, there's enhancement of locomotor activity, while in adults, it actually decreases locomotor activity. Adolescent brain is more sensitive to nicotine's rewarding effect, while adult brain is kind of more sensitive to the aversive effects of nicotine. So this determines how much nicotine you can expose adolescents to. Adolescents don't have significant withdrawal symptoms to the same degree adults do, and high doses of nicotine, adolescents generally tolerated much better compared to adults. And finally, and this is like based off of animal models and adolescent brains, with nicotine pre-treatment, there's leads to other substance use in terms of enhanced acquisition of cocaine, meth, and alcohol self-administration in these animal models. So one thing to think about here is that when I see kids now and they're vaping and the amount of nicotine that they're exposed to is almost equal to 2-3 packs worth of cigarette per day when they vape this similar products. So they may not be smoking, but they're being exposed to a lot more nicotine than the adolescents historically have ever been. And there's also like the product landscape is constantly changing as the FDA continues to regulate these products. We know that flavored e-cigarettes was very popular, and that has been really regulated, and that's kind of constantly changing what is available. And the marketing has also been very savvy because these companies know they are targeting younger population at the end of the day. And I've really been disappointed with the advent of the smart vapes, which are like I'm seeing a little bit more of these vapes in the environment now, where these are devices that have integrated features like video games and music playback, which is almost like it's an electronic nicotine delivery system, but it's also like a digital device in your hand that's you're forced to use because you're playing a game on it or listening to music on it. So in terms of consequences, we again, in terms of hospitalizations are going up related to nicotine. It is not the most significant compared to the other substances, but we're still seeing high rates. And there's also that vaping of nicotine and mental health. We know that there's no causation here, as in nicotine is not directly causing mental health conditions, but there's just so much comorbidity and correlation with when someone's already depressed or anxious, might use nicotine products to medicate, but it can also then amplify the anxiety symptoms and feelings of depression. And surveys of adolescents show that 81% of 15 to 24-year-olds used e-cigarettes to decrease stress, anxiety, or depression symptoms. So it's kind of like this vicious cycle where a lack of access to treatment, increase in prevalence of mental health condition is leading to nicotine use, which then worsens those same conditions, and we're stuck with a lack of effective treatments for these conditions. So main take-home points would be that nicotine vaping in adolescents is linked to increased rates of depression, anxiety, suicidality, and cognitive dysfunction. We should be doing more screening, educating families, and intervening early, because it's challenging in terms of trajectory when the kids start vaping as to what happens. Co-use of cigarettes become common, co-use of cannabis becomes common, and then all the other long-term mental health complications. So now cannabis. I did not want to spend too much time on cannabis only because this is a talk in its own. So I was thinking about what would be the most relevant take-home points at the end of the day. So main things that we talk to kids about is this is not your grandmother's weed anymore, right? We measure the potency of cannabis products based on the percentage THC that is present in the product. And what we know is that over time, I know some of you may be aware, like in the Woodstock era, like the cannabis THC percentage was like 0.5 to 1%. I can tell you, I have a menu from a dispensary that's right next to my clinic in Tacoma, and the average percentage there is 20 to 25% for the products that they sell. So 1% in the 60s to 20 to 25% THC is what we are dealing with a plant-based product at the end of the day. But with kids, what is happening is they are using products that are more than 80% to 90% THC. And one of the main reasons is that these often come in vape forms. They're easier to hide, and they don't have the typical odor associated with marijuana or cannabis. So we are seeing kids who are being exposed to high amounts of THC. The receptors are being overwhelmed by the THC, and now they're coming more often to the hospital. I kind of use this example of I talk to kids. I'm like, you have a friend, one person is drinking a beer every week, and this other kid is drinking moonshine every day. Kids don't usually know what moonshine is, but I tell them whiskey or vodka. And I ask them who would they be more worried about, and they are kind of knowledge about alcohol is ingrained in the society to some degree that they can tell me that they're worried about the kid who's going to be drinking, and they know the reason drinking whiskey or like something with higher percentage alcohol. And we kind of draw parallels with cannabis when it comes to that, to kind of get home the point that what you're exposing yourself to is not just a child's drug, which is how they tend to view it. And we know that cannabis use in adolescents, especially, they have greater neurodevelopmental vulnerability and differential cognitive impact compared to adults who start cannabis later in life. And we spoke about the patterns of use where they tend to vape more and use products with high potency because it's easier to hide, higher risk of psychiatric disorders in early initiators of cannabis, and a stronger reward sensitivity and greater difficulty quitting. Overall, when you look at all substances, cannabis was the most common reason kids are being admitted to the hospital. It's not alcohol, it is not opioids, it's not nicotine, it is cannabis. This is true at Children's Hospital. We see kids for cannabinoid hyperemesis syndrome commonly admitted to our hospital floors. Our adolescent psychiatry unit at any given point, at least half the kids have a co-occurring cannabis use disorder, even that they're admitted for depression, anxiety, psychosis, suicidality, etc. So this is an emerging challenge, and we don't know how this is going to continue as these kids become adults. We know that receptor level changes, brain level changes are happening. From a phenomenology perspective, we still don't have a lot of clue as to what the outcomes might be. Take-home points would be, there's a lot of times when people get into arguments about whether cannabis is good or bad or helpful or not, but I always drive home the point, I stay away from the conversation and I say this. This is proven conclusively. Increased THC is equal to increased harm. That is something that everyone tends to agree on at the end of the day, and I use that as a starting point. Cannabis use disorder does not have any effective medication intervention at the end of the day. Contingency management might be this most leading intervention that we have. Not all places have access to implement contingency management for adolescents, especially with cannabis use. Symptomatic management with medications that people are comfortable with is usually the direction to go in. And I kind of have two parts of kids who come in saying they want to stop cannabis, kids who their parents bring in and they're like, absolutely not. So for the kids who are saying absolutely not, then the goal often becomes working with them to reduce that exposure to THC at the end of the day. Because if increased THC is increased harm, then the thought is decreased THC means maybe there's a decrease in harm associated with it. So next, we're going to talk about alcohol. I really don't have much to say about alcohol, but if you haven't heard about buzz balls, kids in the DMV, this is what I hear a lot about as to their preferred choice of drink. I have no idea why. Overall prevalence, it has declined. So 2024, when I look at monitoring the future data for 12th grade, 10th grade, and 8th grade kids, the numbers have been low. I showed it in the first slide, overall prevalence is low. But there are some interesting data to think about, especially when you're thinking of who to identify as high risk in your clinical population. So we're looking at data for kids ages 18 to 25. I'm going to show data for prevalence of past month drinking, past month heavy alcohol use, and prevalence of past month binge drinking. And I have put this in bold here. When you look at the prevalence and we divide it by gender, you will see that girls, for the first time in the country's history as of 2023, are out drinking boys in this age group. And this is one of the first time this is happening, and we don't really know all the underlying reasons for why this may be the case. This was historically not the case, but it is happening now. And if that's something that I want you to kind of think about in clinical practice. Are you equally screening or thinking of alcohol use in your male and female populations in your clinical setting? But this was like a piece of information that I thought everyone should know because I don't know how prevalent this information is. So what can we do in terms of early detection and intervention, especially in this landscape where we know that we can screen a lot of kids and a lot of them will be negative because the overall prevalence is low, but then those kids that we do screen for who turn positive, more likely to have a substance use disorder. We still need to implement routine screening in all psychiatric evaluations. The question is always, as a child psychiatrist, for me, what is the age to start routine screening? There's always going to be some high-risk kids where we might start screening early, but at least there's one from AAP, the American Academy of Pediatrics, we know that recommendation is to start at entry to middle school, which is when they want routine annual screening to start. Validated screening tools are available for adolescent age groups especially, and these are free to use on the NIDA website, Screening to Brief Intervention and Brief Screener for Alcohol, Tobacco, and Other Drugs. normalize the conversation and having like psychoeducation on the impact of substances. We are going to have a bias because we are seeing an increase in substance use disorders, especially in patients with co-occurring mental health conditions. And how do we really conceptualize treating both with the patient and also kind of not have a conversation that is not stigmatizing or shame eliciting when it comes to substance use is going to be important. In an outpatient setting, the realization is that I'm not going to make significant changes in one visit, but how do we get them come back and keep them engaged in care so we can make meaningful change over time? Involving family systems is going to be crucial. We know that when families are concerned, significant others are involved, outcomes tend to be much better. I have an asterisk on there because consent and confidentiality might often be barriers in engaging family systems, but there should always be an ongoing conversation with the patient about engaging families. And developing safety plans and harm reduction strategies. There are just some kids who are going to try to experiment despite best efforts on our parts, and we still need to have plans in terms of keeping them safe at the end of the day. And finally, starting medications for addiction treatment when appropriate is indicated for all ages. While buprenorphine is the only FDA-approved medication in the pediatric age because the label is 16 years old and above, we still recommend off-label use of nicotine replacement therapy, bupropion, varenicline for nicotine use, naltrexone for OUD and for alcohol use disorder. These are medications that we should be considering early. We shouldn't let that 18 be the benchmark for which we're going to say we're going to start that medication. And so you identify and screen what happens after that. And this is where we need to think of building models where we can contain patients rather than thinking we send them somewhere, they get treated, and then they come back to us in an outpatient setting. There are different ways in which we can think of modeling who to involve from a primary care-based setting, from a primary psychiatric setting, and from an addiction setting. So this was the 4-quadrant method that was conceptualized as principles of care for young adults with co-occurring mental health and substance use concerns. So we really want collaboration with specialists depending on the quadrant that the patients tend to be, right? Quadrant 1, mild psychiatric disorder, mild substance use disorder. This may be someone who's just managed in primary care-based treatment with consultation and support from psychiatry. Quadrant 2 is severe psychiatric disorder and mild substance use. This is someone who maybe just needs to be in primary psychiatric care. Quadrant 3 is mild psychiatric disorder, severe substance use. This may be someone who may benefit from an addiction trained physician. So there's more there. I think the number of addiction medicine trained physicians has also significantly increased over time so that we are able to kind of spread the needs of the system across different providers. And finally, severe psychiatric disorder and severe substance use disorder. This is where you really want addiction and mental health specialists working as one team in order to provide care. The American Society of Addiction Medicine has levels of care that they have, like level 0.5 through 4. Main things to know about here is in the DMV, we don't have access to all these levels of care. We have level 1, we have level 0.5 in DC and Maryland. And level 2 is 1 or 2 programs. There's one program that will take commercial insurance, one program in Maryland that will take Medicaid. Well, that's only Maryland Medicaid for now. And level 4, intensive inpatient, it's for now, Children's National for inpatient for medical purposes. PAW also offers detoxes for their patients, for adolescents and for psychiatric treatment there. Other key things for level of care consideration. Historically, the pattern of treatment used to be sequential, as in you treat one first and then you treat the other. We know that that doesn't work. The goal is you treat both now at the same time. So integrative treatment is the model to follow. And we are building systems where adolescents who enter treatment for substance use do not complete the recommended program. And after discharge, they return to regular use and do not initiate continuing care services. And we're really like, this is okay. We're still going to try to engage them in care at the end of the day. Assertive approaches where a counselor goes to home, goes to school, increases linkage to continuing care and rapid initiation of continuing care. is going to make a difference in reducing substance use at the end of the day. And I put this in bold because at Children's, what we are doing is we are also hiring peer recovery support specialists. So these are adults with lived experience in substance use recovery, and they have a lot of good evidence for helping patients in the adult world. So we're trying to see if we can replicate that model in kids, see if that can make a difference in helping them stay engaged in care. Evidence is sparse, but is accumulating to suggest that matching adolescents to age-appropriate 12-step and other mutual aid groups can support recovery. And research employing adaptive treatment decides hold promise for establishing decision rules as to who needs low intensity, who needs more intensive care, and who needs assertive approaches. So when I have a kid in treatment in our clinic, we often try to see what can we do to keep them engaged in care, what can we do to keep them coming back to our clinic for care, treat that psychiatric condition, treat that substance use condition as intensely as we possibly can, but know that they're likely to fall out of treatment. The issue is really, what do we do when we fall out of treatment? How do we get them back into treatment again? And that's one of the main areas that we are working on. So final take-home points at the end of the day is that the substances used by adolescents have changed. So we're still talking about cannabis, nicotine, alcohol, opioids, right? But these are not the same drugs that were present 10, 15 years ago. Cannabis has changed, nicotine has changed, opioids, fentanyl is what is being initiated now. So we need to kind of think of how this is going to developmentally impact them, they're going to have, what kind of trajectory they're going to have as adults, and how we are going to manage the substance use disorder along with the co-occurring psychiatric disorder. And many of these adolescents are already seeking treatment in the adult care system. And there may be inherent differences in treatment outcomes for them. We just don't know. We're still looking at the data and learning how they are navigating the treatment systems. And finally, more workforce development is needed to address emerging challenges around substance use and how that's impacting our patient population. So just in terms of referral information, the addiction program that I'm at Children's and at Howard, the Children's program has two locations at Tacoma Regional Outpatient Clinic in DC and the ARC, which is in Southeast DC, and I also at the Howard University Mental Health Clinic. We see minors, patients younger than age 18 or still a senior in high school with any substance use or mental health difficulties and substance use problems, and I have the phone number to call. I know I really spoke a lot there, but I am going to open up for questions.
Then, Dr. Kaliamurthy, I'd like to ask you a question, if I might. What about young people who are being treated for ADHD? Is there a risk in prescribing stimulants?
So no. So what we are finding more recently is that, I mean, we always knew that treating ADHD and substance use was like, ADHD is a significant risk factor for substance initiation and developing a substance use disorder. So we knew that treating ADHD appropriately is then going to decrease that risk. And what we are seeing in terms of the data is that prescription drug use is actually on the decline, whether it be for opioids or for stimulants. Overall prescription drug use among high school kids and middle school kids that overall is on the decline. So we would be doing a disservice by not treating ADHD more than the risks associated with actually treating ADHD with stimulant medications. And I think that if I remember right, the data also shows that diversion of the stimulant medication tends to be more common than misuse of the stimulant medication.
Dr. Kaliamurthy, Peter Cohen. I'm a retired doc, but back in '81, there were very few of us that were interested in this area. And it's quite heartening to see how you're thinking through this problem. And to see plus ça change, plus la même, as much as we're changing, we still are faced with these serious problems. So I want to encourage you to continue your research. An area, I used to be medical director at the state level. And back then we were trying to instill not only an improvement in the education of substance use counselors, but outcome measurements on real time, and really figure out what makes a difference, and to try to pick out what parameters you're going to use to figure out whether, I know it's a simple term, does treatment work? What do you really need to do? And we weren't really at the stage of rewarding programs yet. But what we were trying to do is just reward people for actually having valid data so we could start to figure this problem out. Where do you see our field in terms of what happens, if you know, at the state level or at the university level? Anyone you see doing any kind of research that impresses you about which factors, or would you, for example, would you just start with how long you keep the patient in treatment makes a difference? And so let's figure out what you need to do to modify a program to keep kids in. So anyway, it's a broad subject, and I want to listen.
So there are not a lot of trials going on in the adolescent substance use space on this topic right now. And I mean, this raises some of the concerns that we're seeing. The challenge has been historically, so I mean, I have to preface this by saying adolescents are historically not the population that walk in saying, I need help for substance use and co-occurring disorders. And that's one of the reasons we did not have good treatment systems to begin with, because it was not financially viable for many programs to build out a system that relied on clinical revenue alone. And when I started at Children's, one of the key changes that we were seeing is the kids who are using opioids and fentanyl, they were coming in and saying, I want help. And that was a difference compared to the cannabis and nicotine kids who, to date, it's usually the parents dragging them in, or like school or some other like external factor that's influencing their treatment engagement. And so the question that you raised about what factors influences treatment engagement and retention and how well they do, especially in the adolescent population, it is harder to study because we have fewer clinical programs that cater to this population at the end of the day. But I do know of people who are doing this work in the adult side. It's just that when kids move from the pediatric world to the adult world, there's and everyone's probably aware of this already, is that there's a gap in data in terms of like insurance reimbursement data, and like the care systems change, the EMRs change, and that we don't have good studies, like the ABCD study is going on now, which is collecting data longitudinally, but we don't have more large-scale data that's readily available from our healthcare system that helps us study these conditions starting at childhood.
Thank you.
Could I go back to a point you raised about integrative versus sequential treatment? When you see young people with coexisting mental disorders and substance use disorders, do you ever treat one before the other, or is integrated treatment now standard of care?
I think it also, I should put a caveat there in terms of saying it also depends on the substance use disorder itself and the level of care that we're meeting these kids in, inpatient versus outpatient. For example, when I have a kid with cannabis use disorder or nicotine use disorder who also has ADHD, I need to make a decision about treating both at the same time, because the challenge here is that if I don't treat the ADHD, the cannabis use is only going to get worse, or the nicotine use is only going to get worse. But at the same time, if the kid is actively using opioids, fentanyl, or stimulants, cocaine or methamphetamine, I'm not thinking of do I treat the ADHD at the same time with the stimulants? There may be some benefits from kids with that stimulant use disorder, but not so much the fentanyl and opioid use disorder. So that nuance is still always going to be there. And but then the question is, let's say there's a more serious illness. I have a few kids with bipolar disorder. I mean, the question of true manic symptoms in the absence of substance use is always unanswered in this population. But psychosis and manic symptoms, we're still that integrative treatment is going to be very, very important at the end of the day. And if you only think about this from the psychiatric perspective, from a substance use perspective, most of the interventions are not going to negatively affect the psychiatric symptoms. If I think of medications for alcohol use, nicotine use, or opioid use disorders, it's very unlikely that starting medication treatments for those conditions is going to have a negative impact on the psychiatric symptoms that the patient may be facing.
I guess you could stop sharing your screen if you like.
Okay.
Here
Oh, yeah, I can see everyone now.
You mentioned one of my favorite medications, bupropion, which of course is labeled for to help people stop smoking. We've all been concerned, I guess, over the years about the risk of seizures, and I wonder if is that an issue in terms of treating young people with various substance use disorders?
Yes, that is always on the back of our minds in terms of what are the other seizure risks for this kid. Unfortunately, as a child psychiatrist, I've just seen a lot of kids in the intensive care unit post overdose on bupropion having seizures. So I'm very cautious with my use of bupropion. But it's also interesting because from a vaping perspective, from guidelines from professional organizations, it's always been a nicotine replacement therapy or nicotine replacement with nicotine patches, gums, etc. as the first line treatment. It was recommended though it was not FDA approved. But varenicline, or Chantix rather, is now coming up more as being beneficial for this population. Even like a few weeks ago, there was a more recent study that showed that it is effective for vaping with the kids that we are seeing now. So there may be some changes to what professional recommendations are going to come up with.
What's your feeling about a genetic risk of substance use disorders?
Family history is like one of the biggest risk factors at the end of the day. When you're doing an assessment, it's always the one big risk factor we are thinking about. It's the family history is like so big predictor.
I mean, are you able to separate genetic from environmental? I mean, I guess like I would imagine if young people see their parents or other relatives using substances, that would be a model, no?
Yeah, so the way we think about it is, so there's the family history as a risk factor, which is high, and then the second is the adverse childhood experiences. So we know that the more the adverse childhood experience, then more likely the kid is going to have a substance use disorder. And then the likelihood that within family substance use can lead to certain adverse childhood experiences is quite high. So it might not be a direct causation, but there may be linkages there that we need to think about. But it is also true the other way around, where we know that even with kids who have significant ACE scores, like the ACEs score, having one adult in their life they can look up to can be a very big protective factor. So when we're working in the community, we often try to find that adult in that kid's life who can be that source of support that can change the trajectory for them. So that's how we delineate environmental factors from genetic factors. Or at least that's how I do it.
Are there twin studies in terms of, alcohol, opioid, weed, any of those in terms of the risk, the genetic risk?
I don't know. So I know twin studies where they looked prospectively in terms of outcomes. I don't know if they looked at it the other way around, the genetic risks. But when we do have twins and you introduce substances in one twin, then their likelihood of having psychiatric conditions is higher. So there are twin studies along that I'm aware of looking at that specific question.
Hi, Dr. Kaliamurthy. I have a question. I am Dr. Fernando, and I work for the Fairfax Falls Church Community Services Board. I'm a child and adolescent psychiatrist. And you were talking about the potency of THC. Do you recommend that we have a very hard time getting kids to come to treatment for THC, even though we see that it affects their functioning to such a very significant level? Do you recommend that we discuss with them or educate them about the potency and decreasing using THC that is less potent?
So, I mean, as physicians, as providers, I think the message is always don't use drugs.
Yes.
So that's like the first line. And then the second line is that awareness that despite what we say, the kids are going to use drugs.
Yes.
And how do we navigate that fine line? And I do often talk to the kids and the family members, because when kids are using the high potency products, it's often because the parents don't like the smell of weed, and they're trying to hide it. But then the parents know that it is a problem by the time they're seeing me in the clinic. So we try to figure out, and the kids it's not just that they're smoking weed, but they're not going to school, or they are engaging in other behaviors like running away from home, carjacking, like there's just a
Yes.
lot of like conduct like behaviors that accompany it that parents are aware of and want to change. So we often then work with them to like talk about, can we then reduce the amount that you're using? And
Yes.
we do talk about the flower and bud products probably being an alternative in terms of how much THC percentage it has. But it's also, the question is, there are now studies coming out, reviews coming out that looks at how much should a person reduce their cannabis consumption by to have any meaningful mental health gains. And one of the most recent reviews found that you need to decrease the potency of the product by at least 75%. And then once you
Wow.
do that, you need to reduce the frequency by at least 50%. And that shows meaningful positive mental health benefits. So
Okay.
these are some artificial thresholds that we try to set for the kids. There are good like if I have a kid and I can get them to watch some educational videos, the Stanford has a cannabis toolkit that goes over a lot of this information from both a prevention perspective, but also a harm reduction perspective.
Okay. Thank you so much.
Do you see a role of social media, either positive or negative, in driving substance use in young people?
Yes. It's a great question because it is positive and negative in terms of access. When we talk about ease of access, drugs being delivered, a lot of these drugs can be ordered online and they're being delivered home. And so that ease of access does play a role. Don't ask me for the data on this, though. So this is like anecdotal from my patient population and how they get access to these substances. And in terms of the benefits, though, it's also an avenue for us to intervene and educate kids because they're already there. And it's like the constant fighting that misinformation by providing them with actual useful information. I know, and this is like a belief of mine, and I know I hope this is shared by most people who work with adolescents, is that if they are given the right information, they will make good decisions for themselves. And unfortunately, many a times that doesn't happen. So social media can also be used from a positive perspective in terms of addressing that misinformation gap that they have.
Okay, that's good to hear.
I have a question.
Well,
It's not anything relative to treatment, but I wondered about the advertising of the products. You mentioned something about them looking like a video game or listening to music. I mean, back in the day, I know I worked at a cancer center and we had kind of a full force legislative effort towards trying to keep the advertising away from children, make it to, I mean, because they were like advertising it to be a really cool thing to do and all of those things. Is there anything, I mean, I don't know if there's anything like that being done or if you know about anything, but I wonder if that might be something that could help.
So yeah, I'm by no means an expert on the policy side of things, but I do know those policies already exist. But the companies do get around that in terms of the marketing strategies that they use. Often they may say it's for young adults, but you look at the content and it's very appealing to the pediatric age group as well. So I don't, even if there is a policy in place, I'm curious to, like, I would be keen to hear if anyone here knows how it will be implemented and who would be held accountable. And like Juul was held accountable as a company at the end of the day, and they were shut down. So there were some benefits to that, but like, for example, in the beginning, when vapes became a hit, Juuls had these replaceable cartridges. So they initially said no more devices with replaceable cartridges. And then they had these disposable cartridges, and then they said no more disposable stuff. And then they had rechargeable disposable stuff. So every time there's like a new rule or a policy, they get around that with the change, like a different device. And these devices are not even regulated. Like half the time, even my patients will tell me they have no idea what's in these devices that they're using right now. And there are the regulated devices, but they're very expensive, and kids don't usually use them. They don't buy the regulated products because they're significantly more expensive than the unregulated ones that they can buy online or in the illicit market.
Hey, well, our hour is drawing to a close. Dr. Kaliamurthy, I want to thank you very much for a very informative discussion. If you have any last words for us, I'll give you the last few seconds are yours.
Thank you. I mean, this was a wonderful discussion. It was nice to meet everyone. I mean, I am a member of WPS, but unfortunately, I've only been in DC for about 2-3 years now. So this is my first meeting. I'll try to be more of a participant.
Okay.
Yeah, but please feel free to email me, reach out to me, and I'm happy to answer your questions offline. I'm on the listserv.